A shared pleasure. Oh, you want to use this instead? Oh, okay. All right. Welcome back from the break, everyone. We're just gonna get started with our next speaker. All right, so next up we have Dr. Mariano Kanamori. We are going to have the pleasure of hearing him speak about the role of community and clinical settings in scaling up EBIs and using community-based participatory research and also working with non-conventional partners. Dr. Kanamori is faculty and division director of the Prevention Science Division in the Department of Public Health Sciences at University of Miami. Dr. Kanamori holds an extensive program of NIH-funded research, much of which is focused on implementation science and working with Latino sexual minority men and other Latino communities as well. Dr. Kanamori is also a co-director of the Equitable Implementation Science Core of CHARM and a wonderful colleague as well. So thank you so much for being here, and we're looking forward to hearing from you. Thanks, Mariano.
Thank you, Audrey, for that great introduction. Okay, so today I am going to talk about community-based participatory research and how I have been able to use social network analysis to implement equitable research. And at one point, Dr. Stephen Fallon from Latino Salud, who is my community partner, is going to join us via Zoom, and he's going to share his impression from the community perspective. So when I came here to Miami in 2013, I asked the Latinx community how they describe themselves, and the answer that I got was, "We are invisible. Nobody cares about us. They are not services for us." So my goal since then has been to change that situation. And I have been fortunate to start my career development with some pilot studies funded by CHARM, funded by Claro, and then these grants, pilot studies lead to different R01s and TP1s. So it took a lot of time to be to have these R01s. So it's not something that happened from one day to the other. And the literature and my experience says that generally it takes around 10 years to really have a true community-based participatory research. It's not something that you are going to develop from one day to the other. Now, the other thing that you can do is to find a mentor who is also engaged with the community, and then you can benefit from that, and then you don't need to start from the beginning. So finding through my K99 shows that half or more than half of Latinos here in South Florida have been exposed to some type of discrimination, including being worried about accessing immigration legal services, having questions about their legal status, and feeling tense because of judgment or intolerance due to their inability to speak English. So what is CBPR? So the first definition is the CBPR involves community, and the involvement in community is essential for the identification of health concerns and interventions. And the reason why I included this picture is because if you want to implement CBPR, you need to get wet. You cannot be the person who is just watching from outside, from the border, and seeing how other people swim. You actually need to swim. So in other words, if you want to implement CBPR, you need to make sure that that is something that you want to do. CBPR is not for everybody. Some people don't want to do CBPR, and that is fine. Some people want to do clinical work. Some people do not want to be involved in the community. I have conversation with some students who wanted to enroll in my class in the CBPR, and I asked them, "Why would you like to take my class?" And say, "I don't know. They are forcing me to take this class this is part of a program, but I really don't care about the community. I care about doing surgery, and I don't know how I can do surgery with the community. And so I said, well, let's talk on this. So this is not the right course for you. And I think that it was a win-win situation. Isn't it? So the other definition of CBPR is that that all of the partners should be equal. So there is nothing about have more knowledge or you have less knowledge. I'm going to teach you or I am going to learn from you. And even for budgeting, when the partnership evolve, then there is an equal involvement in the development of the budget actually. But that doesn't happen at the beginning, isn't it? Because you don't know the community partner, and they generally start with a small work, but they generally tend to implement a large part of your project. So then you need to actually divide the budget almost in half, and sometimes even more than half. But now let's include equitable research best practices. So as a result of our natural cognitive processes, experiences, and social environments, all individuals have implicit bias. Researchers and teams should engage in ongoing effort to acknowledge this implicit bias by conducting research, identifying areas of personal implicit biases, engage in constant self-reflection and strategies that will address this would address it. I will just share with you some of one implicit bias that I have about me. So when I wanted to work with pharmacy chain companies, I thought, oh, I should introduce me as a Mariano Kanamori, the faculty, with my suit. And I did that with 3 companies. They were very welcome. But at one point, the partnership didn't complete because of some policies from the companies. But then I said, I want to approach CVS Health. And I said, well, but I go to CVS Health all the time. So how can I go with my suit one day? And one day they already know me. So what I did is I went after going to the beach with my swimming suit and my flip-flop, and I approach my pharmacist and I said, um, you may not believe, but I am a faculty. And I have an idea. And I would like to work with CVS Health, and I need your help. So he just went back and he said, okay, so I think that you should contact this person. And if this person doesn't help you come back, and I'm going to put you in contact with another person. Well, I called this number, the person who answered was very nice, was listening, and I was very lucky that the person sitting next to her said, well, excuse me, this is a project for me. I am the one who's going to collaborate with Mariano. And that is how everything started. Then we developed this good local connection. After 2 days, somebody from CVS Health from California was flying to Miami to talk with me about my ideas. And then later, the directors, the leadership wanted to be involved, and they wanted to be the actual partners for this initiative. So what I'm trying to say with that is that if you want to build a partnership, you need to be creative. You just need to do it. No, if you don't do it, nobody else is going to do. And sometimes, if you just see a potential partner in front of you, you just approach it, and then you ask for to have a conversation. Not, so what are the CBPR benefits? Well, first of all, it helps ensure that research is relevant for patients, providers, and community and policymakers. It helps increase practicality and validity of data collection and analysis. And I will share with you another experience that I have with the community partner Caridad Center. So we were working with low-income Latinx, and I was under the impression that the interviewers need to be male because, they were going to interview male individuals. But when I went to the clinic, they said, no, these guys trust us women. And because we are the ones who do the HIV testing, we give them counseling and everything, and they are going to tell us everything. So this is what we did, and we were very successful by having female interviewers doing interviews with males, and these questions related to HIV related behaviors, substance use, and they were very open to answer this question. In addition, CBPR improved the likelihood that our studies are going to be disseminated widely and used effectively to create positive impacts on health. So what are the differences between the traditional research and community-based participatory research? And now I'm going to expand this with equitable research. So in regard to the identification of the health topic in CBPR, we involve the community. The community, contributes in the identification of the health issue, and it focuses on the community needs. In the traditional research, everything is based on epidemiological data or some priorities that the funding organization have. Now, in equitable research, in addition to what we have in CBPR, we also conduct a landscape assessment. We want to understand who is affected, both positively or negatively, by the issue that you want to study, why they are affected, how they are affected, and also what are the historical and cultural experiences and context of the community. Now, when I said who is affected positively and negative, I am part of the lead program, and some faculty members said, I am experiencing discrimination, but not discrimination because somebody is doing something to me. It's because they are not including me. So I am not part of this committee. I am never invited to this conference. All of my colleagues are invited to give talks. I am not. And this is how it fits. So it can be by doing things or by not doing things, but not inviting people, but not including them. So regarding the study design and the funding request, in CBPR, we include the community in the study design, and we want to allocate funding for the community. But in the traditional research, everything is based, the study design is based on scientific rigor and feasibility, what had been published before. And the funding primarily is used for research expenses. Now let's go to equitable research. Researchers who consider the following questions. Are the community values represented in the research question? Have the researchers identified how the answers to the research questions will benefit the community? Do the research questions account for the cultural and historical context of the community? And does the community respect and trust the research design and type of data collected? In regards to participant recruitment and retention, in CBPR, we want to ask the community, how can we retain the participants? And in the traditional research, everything is just it's based on our best guess. Now, in equitable research, research teams should be diverse and ideally include members of the community being recruited. I am a believer that your lab should also be in the community. And sometimes people ask me, well, you have all of these projects, but you don't have a lot of, your lab is not that large. Well, that's because of my lab members are part of the community organizations. So I am covering their time and they are working for me. So they are not coming necessarily to but they are working in the community. So we need to ensure that all team members are well versed on purpose of the research in general, on all of the specific of the study regarding recruitment, regarding disease conditions, and the benefit of relevance of the affected community. And we need to ensure accountability to approach all participant families regardless of language, race, ethnicity, and other identities. And I'm going to show you how my social network approach actually allowed me to identify that I was not doing the right thing, that I was excluding some people without noticing it. So in regard to measurements, instruments, and data collection, again, in CBPR, we include the community to better handle sensitive issues. They tell us how we should formulate these questions. And especially, I have some problems, especially when I have questions regarding drug substance use, because I don't use the same language. You know, now they have different names for the same substances. You know, and the community helped me identify the best way to formulate these questions. But in the traditional research, you know, we use the same questions that have been adapted from other studies and are valid, and we do not involve the community. You know? So we just ask the question as is it. In equitable research, we need to reduce language and cultural barriers. Interpreter must always be present when applicable and have the team employ and teach back every time, considering hiring bilingual study staff, so interpretation is not required. For instance, in our one-stop shop PrEP program, we ended up asking the participants what they understood from the session, you know, to make sure that they got the message, because sometimes we just tell them the message, but they may interpret it differently. The community always review our translations, and we ensure that the language regarding government, federal agencies are clear. I don't know if they can be consent because now IRB is asking you for all of these additional text that you need to include in your consent form. In regards to the intervention, design, and implementation in CBPR, you involve the community, and in traditional research, everything is based on theories. In equitable research, you minimize trial requirements, so you want to conduct activities that are needed for the community. You provide stipends to compensate for time and travel. You ensure that the type of stipends do not cause concern for some groups. For instance, we always consult with our community partners regarding the amount that the participants should receive, because if we give them too much money, then they will have problems with their services because they may give them less money and then they will complain. No? In addition, sometimes some communities prefer a gift card from Amazon because they have access to the internet or computer. Other communities, such as the farm worker community, they do not have that access, so they prefer a gift card from Walmart because this is where they go to buy these things. We need to provide childcare activities and food when needed, and we need to provide transportation alternatives also, such as Uber. In regards to data analysis and interpretation and dissemination, and this is ideally because you cannot force the community to work on this because sometimes they don't have time or they don't have the interest to be involved in the data analysis. But ideally, you want to include the community in the data analysis and interpretation. We have particularly trained our community partners in social network data collection and some of the basic data analysis. So now they understand why they are collecting this data and how the findings have been used. And from the traditional research, we only use the statistical analysis and we disseminate our findings in journals. In equitable research, we want to disaggregate data in quantitative analysis by race, ethnicity, language, sexual orientation, zip codes. We want to explore the intersectionality of race with other dimensions of identity. We want to present findings to the community in accessible forms. And if a profit is made from our study, it's important to share that with the community as well. And when I say that profit, sometimes, if you have another study that builds on the current study, you should continue with the partnership and don't just finish the partnership. You should continue involving them. So let's see, are you ready to apply CBPR to your project? That's the question. Let's see. First, you need to have a general knowledge. The first thing is that you know that you want to include CBPR in your project because, as I said, not everybody wants to include CBPR in your project. You know or are willing to know the community cultures, economic conditions, social network, political and power structures, norms and values, history. I have been approached by some colleagues who wanted to do research with Latino MSM. And I always ask, so why do you want to do this type of research? And sometimes they say, well, because there is funding. Okay, so that's, I guess this is important, isn't it? Because you want to do research when if there is money. But I said, okay, let's go to a gay bar this weekend. And you can actually go and be in the testing band, so you can see how the community approach Latino MSM and how they interact inside a bar. That's the end. But I don't know, to me, it's normal to interact with Latino MSM, but for some people, it's not normal. They are afraid. They are afraid to interact with this community. So you need to know that you really want to interact with this community. And you want to learn the community perceptions of you and your organization. Readiness. We need to know if our university is going to support our work. First, we need to understand whether our university supports CBPR. We understand that we have the time to invest and develop community relationships. That we have a mentor who have CBPR expertise. We have determined the university roles and their role in the project. We have identified potential sources of funding, and your time is not fully commitment. But then when you're starting to get successful, that's something that can be flexible. But, and that is important because, for instance, for promotion or for tenure, sometimes they will not value CBPR research because they will say, oh, but you didn't publish anything from your study. Excuse me, but the CBPR study takes 10 years to be implemented, It's like the EHE studies. We started a few years ago. Now we are starting to have some findings, but we cannot have final result at this point. It will be easier to actually use and do secondary data analysis and have 50 publications, but that is not a person. It is not a person who does CBPR. No? So you need to understand that the university is going to support this type of study for the promotion and for the tenure, that they will know that this type of work takes time, and that is not just words, but they actually value the community involvement, that they want to serve the community that is in our backyard, okay? Sometimes they are universities who just want to focus on teaching, and this is what they evaluate. They don't evaluate this type of research. Regarding your skills, we need to understand that we can set project goals, identify research opportunities, can design and implement projects, and can evaluate the results. In regards to our attitude, we need to have sensitive listening skills, not judgmental receptivity, and willingness to learn new skills. we and our organization needs to be prepared to share control. Sometimes that can be an issue because sometimes our community partners do not have the infrastructure to process all of this paperwork that the university requires. And we need to help them. We generally fill all of the documents and then you show that to them and then they approve and then they sign. But they do not have the infrastructure to do all of this billing and to sign all of these forms that are required to establish the partnership. Now, it's important to find whether this community partner is a good fit for you. Not every community partner could be a good partner. So the first thing that I want to say is like the assessment of the partner's goodness to fit is like the dating phase. So you do not make the commitment in the first meeting. You need to understand more about the community, and you need to give them the opportunity to learn more about your research approach. So key indicators of goodness of fit are shared values, compatible climate, mutual benefits, and commitment. For instance, if you want to implement a project in HIV prevention, you want to make sure that the advisory board likes that topic. Sometimes they don't like to be associated with the gay community. Sometimes they don't want to be associated with things related to HIV. And so this is not going to be a good part. So you need to, regarding the visions and goals, you need to feel comfortable with their visions and goals, and you need to have similar visions and goals. You need to make sure that they have a good credibility. You need to investigate the organization, learn the history, reputation, and effectiveness. And you need to learn from the past, whether they have done something similar before, whether the leadership is engaged, whether their members and staff are stable, and there is nothing negative that you do not know. In regards to the environment, you need to discuss what will be the best way to communicate, how decisions are made, and what is the pace and timeless for the project, and the timing. This is important. You may find the best community partner, so you're ready for a marriage, but it's not the right timing. Maybe they don't have enough staff, or maybe they have too many projects. So that is something that you also need to take into account. And in regards to the organization characteristics, you need to make sure that they represent the population of interest, they have a strong ties to the community, they can reach the population of interest, that they have previous experience doing outreach, they have experience to set with outreach, they can enter into legal contract and staff management can report the requirements. I was recently contacted by the Miami-Dade County, and they wanted to ask me some questions related to Latino salud. And I said, yes, of course I can answer any question. And I said, but why? And they said, well, because there are many organizations that are formed by the husband, the wife, the kid, and the grandfather. And they just sell themselves as a community organization. And they are receiving funding from Miami-Dade County. And now they are trying to identify which one are the real organization and which one are the fake organization that are just basically based on a family. So now I'm going to discuss our journey, the journey that I have with Latino Salud. So pretty soon, Dr. Fallon is going to join this presentation. So our work focuses on social network analysis. And I want to briefly share with you what are the differences between the traditional research and the social network analysis research. In the traditional social science research, the unit of analysis is the individual, and we want to understand if there are associations between some characteristic of the individuals and some health outcomes. And our data look like this. That is the traditional data that we always use. But in social network analysis, our unit of analysis is the pair of individual. For instance, Latino seasonal workers who are friends. And we want to analyze how this relationship influence their health in a positive or in a negative way. So again, in social network, it's not the individual, but it's the connections of the individuals. That is what we want to understand. And there are two important components in social networks. One are the nodes, and the nodes can be individuals. Everybody in this room is a node. Okay, you have a node, you are a node. So now actually what you have, at least you have learned something. You can go home and say like, I am a node. At least you have learned one thing from this lecture. Okay, so in the studies, they are Latino MSM, 20 to 39 years old, and they meet the CDC criteria for PrEP. And the ties are the connections between nodes. No, they can be friendship connections, it can be connections related to sexual partners, drug use, and PrEP conversations. Today, I'm going to just talk about two specific social networks. The first one is the sociocentric network. In the sociocentric network, we know everybody from the network. For instance, one example of this network will be this attendance for this week event. I know everybody, and then I can ask, who is your friend? The level of attachment, if you trust this person or not. No, I can just ask those things. In the egocentric network, I interview one individual, and this individual provide information of his, her, their network. For instance, I may ask you, I want to know about your drug use network. So you give me the initials of those drug use partners, and then you give information about them. But I do not interview your drug use partners. So everything is based on your report. So this is the approach that we had developed in the lab. So first, we identify seeds or people who are leaders from the community. Each seeds invite 3 friends, and each of these 3 friends invite 3 additional friends. When we have this group of 13 people, we create a network. So we have a sociocentric network because we know everybody from the friendship network. And then we are starting to collect sociocentric network. Then each individual provides information of his sexual network, his drug use network, sometimes it's a service network, okay? And then we also collect information regarding drug use and GIS data. So let's talk about some results. Regarding the friendship each dot here is a node. Nodes is a participant. Okay? Here, each line represents friendship. So something important, I think. So something important that we can find in this type of analysis is whether these friendship group are dense or they are not dense. And the strategy will actually change if you have a very dense friendship network or a non-dense friendship network. In social network, you can also identify who is popular and who is not popular in the network. And I think that this information will be very important to identify who has been reached by some PrEP programs and who has not been reached by PrEP programs. Who will be the best person to disseminate information about PrEP? Who is isolated? The person who is isolated is not getting any information about PrEP. And we can identify the characteristic of these individuals So then understand whether our project is actually reaching those who are at higher risk for HIV. We were able to identify that this network have the potential to reach both PrEP and non-PrEP users. And we went up beyond that, and we wanted to understand the association between substance use and PrEP conversations and the probability of, or the self-perception of actually convincing their friend to use PrEP. What we found is that cocaine and ecstasy actually play an important role. People who use cocaine or ecstasy were more willing to, or were more likely to actually have previous conversation about PrEP, were more willing to talk about PrEP in the future, and they thought that they were going to be able to convince their friends regarding PrEP use. The opposite was regarding marijuana. It decreases. So then we went to the community and asked them, so why do you think that this is happening? And what they said is like, if you use cocaine with one of your friends, you at least need to have some level of connectedness, a level of trust, because you don't use cocaine with anybody, This is what they told us. In regards to marijuana, they said, every time we go to a party, they just pass the joint, and we never know who is actually sharing the marijuana with us. So that may be one explanation of why this drug plays important role. We found that only 4% of our participant sexual partners regularly disclose PrEP use, and 17% of our participants disclose their PrEP use status to their sexual partners. So this has allowed us to understand that we needed to go beyond the Latino MSM community. What we found is that Latino MSM who identify as gay were not disclosing their PrEP use with bisexual men. They believe that having sex with a bisexual person or a straight guy was safe. So they didn't use PrEP and they didn't use condom. They wanted the impression that it was safe to do that. So it actually shows that the use of social network can expand interventions by reaching bisexual men and their female partners. But we went beyond and looked at the geographic overlap of sexual activity and drug use. And what we found is that, so here, each blue polygon represents an area where Latinos MSN have sex or find sexual partners. What we found is that they have sex everywhere. And that is different than the previous paradigm when we need to go to a bar or to a sauna to identify them and implement our activities. Now, no, they are going everywhere. But we went beyond that to understand whether the overlap between drugs use and sexual risk overlap in the same way. And what we found is that that is not the case. So there are areas where people buy and use cocaine and find sexual partner is different than the areas where they buy and use ecstasy and have sex. So that is something important if we want to design strategies for people who use substances, because it differs by the type of substance that they use. So now let's talk about finishing HIV. So what we learned is that we should include everybody from the community, those Latinos who are part of the gay community, as well as those who are not engaged with the gay community. So we did that by implementing 4 social networks. First, we have the social and friendship networks that includes different community activities targeted for the gay community, such as movies under the nine, yoga at the beach, gaming days. We also have a community radio soap opera program that was broadcasted twice daily to more than 270,000 listeners here in South Florida. We also have a parts network, and we distributed more than 800. I think that Dr. Fallon has joined us. I think that I need to admit him. Admit. Hello, Steven. Participants can now see your application. That is good. Hi, Steven.
Dr. Kanamori, hello.
Hey, good, good, good. Can you see our screen?
Oh, my old eyes are having a little trouble focusing, but I see the basic layout.
Okay, you already know this talk, so it's fine.
Very good.
Okay, great. And my eyes are smaller than yours, so if I can see them, you can see them. Okay, and then we have the pharmacy networks. And then when we place posters and distributed more than 14,000 flyers regarding PrEP information and the Latino Salud services. And we can see here some of the Latino Salud work and impact that from 2022. And let's focus on PrEP. They have more than 1,500 PrEP clients. So the work that we have implemented with Latino Salud allow us to identify settings where we can reach and engage Latino MSM. And for instance, here you can see different activities, yoga at the beach, movie nights, gaming nights, art events, sport events. And we also were able to identify how to engage Latinos who are not necessarily part of the gay community. And we work with Latino, with CVS Health, and we design different strategies to reach and engage them. But we also wanted to understand whether everybody will be reached, and that is part of the equitable research. And we want to know that our services are provided in the right places or in areas with the highest HIV incidence. And here, we can see our activities in the left, and then we have here the accessibility. And we can see that the majority of Latinos will have access to at least one of our services provided in less than 10 minutes drive. So now let's go to diversity PrEP. And the diversity PrEP, the goal of this implementation science project was to understand modifiable factors on the behavior of practitioners and support staff, clients, and stakeholders influencing the adoption and implementation of a culturally tailored PrEP program for Latinx men. For instance, what we learned is that for Latinos wanted to use PrEP because they wanted to help their community. They are doing that because they feel responsible. They wanted to help the whole Latino community. Non-Latinos wanted to take PrEP for their own benefit. And that is the difference between Latinos and non-Latinos. So Latinos said, we want to have projects implemented at organizations such as Latino Salud or neutral venues such as pharmacies. But non-Latinos said, I would rather receive my PrEP information from my provider. So that was something different. Religiosity plays an important role in the for Latinos as well. Here, so you cannot read well. It's not the size of your eyes, it's actually the quality of the slide. So we have here the ERIC strategies for the one-stop shop PrEP program. And here we have our logic model, the logic model that we are currently using. And here you are not going to see that, but in the mechanism section, we actually have design and a strategy that is differentiated for people who are already part of the gay community because they may already know about PrEP. So what we do is we facilitate access to PrEP. And there are others, Latinos, who do not know anything about HIV or PrEP. So what we do is first, we inform them, we give them information about HIV, about PrEP, and then we involve them in the one-stop shop program, and they get the navigation program. So once we learned everything, we decided, or we were lucky to have our finishing HIV project funded. So finishing HIV uses or recruit participants at Latino Salud events and CVS Health. So they are randomized to finishing HIV or to a standard health promotion. In the finishing HIV strategy, we form this friendship social network. So we actually promote conversations about PrEP. We were able to have network visualization, and we can identify which individual will be the most popular and the one who will be most likely to disseminate correct information about PrEP. Because remember, we can have good leaders and bad leaders, And we collect information at baseline 6 and 12 months. And this is what now we are, the next phase of this work. We are, like Latino Salud is going to train PrEP navigators who will be at CVS health pharmacies. And they are going to implement a successful program and approach that Latino Salud has implemented in the community. In addition, in the other arm, they are going to receive our social marketing approach, our social marketing instruments, as well as our radio soap opera programs. And the goal here is to have a nationwide PrEP program that is based on pharmacy chain. So now I am going to share with you a video that Dr. Fallon has shared with me, so you can have an idea of the approach and services that Latino Salud provides.
It's a new day here at Latino Salud. Inside these doors, there's something special. A safe space for gay Latinos, for their friends and partners, for the entire LGBT community in South Florida. Inside these doors, we've got your back. And the counties with the highest new HIV rates in the nation, our bilingual, certified, professional staff take the anxiety out of visiting a clinic or getting a test. Inside these doors, we offer health education without judgment, screening that isn't scary, case management that activates, and healthcare without copays. We always make it easier for the community to access services. We take the wait out of waiting rooms. We accept walk-ins and appointments. And we stay open later than any HIV STD agency in Florida, to 9 p.m. nightly. Both in and beyond these doors, we're also offering more free community engaging events than ever before. Our events bring guys together for recreation and connection. They build resilience and confidence. What's it all add up to? Last year, we served more community members than ever before, over 12,000, and we doubled the number of patients we're maintaining on PrEP, the pill that prevents HIV. And we're taking other big steps. We're now providing healthcare for everything from hypertension to hyperlipidemia, from diabetes to hepatitis C. Our ACA health insurance support program pays the monthly premiums for hundreds of our patients in greatest need. And our new health and support service Pride scholarships are closing the gap by developing culturally attuned South Florida professionals in careers such as nursing, psychology, social work, and public health. How do we fit all these programs in? 3 years ago, we tripled our space in Wilton Manors. Last year, we added a new North Miami location. And we're still growing. This year, our new location in Miami Southwest will offer even more counseling rooms, testing rooms, and provider suites, all in a welcoming event space to empower our community. You've always dreamt of a place like this, a place where you can come as you are, get the services you need, and build your best life in good health. You made it to Latino Salud. Welcome home.
No, yeah. Well, I want to please ask you to have a round of applause for the work that Latino Salud is doing. And Dr. Fallon, I hope that you can hear. Are you there?
Yes, thank you.
Okay.
Perfect.
It was very loud, just in case. So, so now Dr. Fallon is going to share from his perspective and the conversation that we have before some of the ideas of why we believe that we have a successful partnership that started in 2017. So, Steven, you're welcome to share.
Thank you, Dr. Kanamori. So everyone, I can't see you, and you know what that's like talking to people we can't see. So I don't know what your particular experiences are or which type of research you hope to be involved in. Some of you will be doing qualitative, some quantitative research, some will be survey-based, some of it will be clinical device trials. But across all of these media, what we've learned in our experiences working with researchers is that some things tend to stand out as key elements of success, and some things present potential barriers. Dr. Kanamori has summarized many of these right here. I'll give you a high-level view of what we've sort of learned through trial and error. When you approach a community-based organization to enter a research partnership, that partnership begins with your very different perspectives. I don't mean Latino, not Latino. I don't mean gay or straight. What I mean is the unique perspective that you have working in a research setting at a university versus the perspective of most of the folks who are going to work at a community-based organization or a clinic, whether it's Latino Salud or another one. The first lens that you probably hold in a different viewpoint than your potential partners has to do with time. The organizations that you go into and suggest a partnership with, their lens is focusing on time right now. They need to help the client who shows up in their doors right now. They need to meet their goals for their grants and projects this day, this week, this month. Your research, by definition, is designed to study things, to prove or disprove a hypothesis, so that findings can be published that can eventually inform people to perhaps create an intervention that might be rolled out, as Dr. Kanamori said, perhaps even nationwide. But that is a long-term time perspective. It does not mean that either of these are right or wrong. What it does mean, though, is that researchers often enter into a partnership with a community organization, and their lens is on, well, I've got to get my IRB approval. I need to form my committee. We'll have to have our HIPAA forms and our confidentiality statements all translated and approved. Then we'll start a project sometime. I don't know, maybe it'll be in 2 months, maybe it'll be in 6 months, and then we'll get it rolling, but then we'll hit a pause because we're adjusting the study. And all of this will strike people in the community clinic as, well, that's never going to happen. We'll get to it when we get to it. So if you explain to your partners, what do I need from you right now? What am I going to need going forward? Just so you know, what are we thinking this is going to lead to in the long term? And then they explain back to you, well, here are our resources. We only have so many rooms right now that we can interview somebody or give a survey or have your staff do a focus group. Which month are you talking about? It's all about the time. Very much related to that is trust. Because you come up with an idea and submit a grant proposal, and as you know, the reviews take time, and then once the project's finally funded, quite often you find out, by the way, we're starting next month. It's almost immediate. And you're pulling things together quickly, and you want to get subjects. So there can be a tendency, we've seen this from some other researchers in the past, to come in, sort of drop some compliments, flatter, fluff, fluff, fluff. By the way, okay, if I leave some flyers here to recruit for my study, and then they leave. In the researcher's mind, that might be the most efficient way to get the subjects the researcher needs for their study by running into a lot of community-based organizations and clinics, dropping a bunch of flyers, and hoping that this sort of shotgun approach will lead to some rate of return. You know, I'll get 2 people from that organization, 1 from that, 5 from this, 2 from that, and it will add up. I'm going to suggest, instead of smiling, flattering, and dumping flyers, doing what Dr. Kanamori does and really setting up a partnership of trust. Here's what we're thinking as researchers would work. And be prepared, you might hear from your community partner organization or clinic, no, that won't work for our clients. No, they need to be to work. They can't spend that much time. Or no, between taking their lunch and paying for parking, the stipend you're offering just isn't worth it to them. Partners like Dr. Kanamori hear that, take it in, work with you, and then the community partner too should revise a little bit. Okay, well, we would have liked to have a survey that could be done in 15 minutes, but all right, we can go 25 minutes. We just can't go an hour and a quarter. Well, thanks for bringing the stipend up for the participants. We wish it was a little bit more, but we appreciate that you made the effort. You're going to get more people participating because you took it up the extra $20. That trust means that you can work possibly even just with one partner. And since they are fully trusting and involved with you, you're going to get more participants than if you just scattershot recruitment efforts without that level of connection. And then the last difference is control. You are doing perhaps even double-blind controlled research studies, which means that anything that's variant from the protocol, you need to have it approved. You need to have your sort of chain of custody of your paperwork. Don't color outside the lines. These are the subjects that are eligible for the study. These are the subjects that aren't. It can only be done in this setting. It can only be facilitated by that person. And you don't want to break rules which could muddy your data. Completely understandable. But sometimes that level of control is in conflict with the community-based organizations or clinics. Their modus operandi is to solve problems. I've got somebody right now who's scared to death because they can't get their medication. I've got somebody right now who's housing insecure. I want to solve problems, help them, help them, help them. If you're a researcher and you're saying, well, we're just not getting the numbers. We're just not getting the numbers. You need to recruit more people. You need to just keep recruiting so we get our numbers. Please have your ears open to the community partners who might tell you, well, this is the one barrier. Can you go back to your IRB committee? Because we think if you could change this one barrier, we can increase recruitment significantly for you. We've had studies that have said to us, we want to vet the participants before we send them to you to then do the data collection. And sometimes that's gone very, very, very slowly. And we've said, how about you train us to vet the participants for you? And we can then do the ones that we think meet the terms. And you can throw them out if they didn't, but we'll do the vetting for you. And we've had our recruitment go up by a factor of 3, 4, even 6 times higher, benefiting both parties, rather than us wasting time, spinning our wheels, recruiting people who are going to find out they don't fit because of one variable. You teach us that variable, or sometimes we've even talked about, can we adjust the variable? Can you go back to IRB and can you say, all right, we'll accept up to age 50 instead of just 45. Or, okay, we'll accept occasional substance users rather than regular substance users. Or, okay, we'll accept people because they are interacting in Miami-Dade, even though their zip code is Broward County. Whatever the variable may be, let's discuss it. You keep the control that you need to make sure your data is useful, but be open to hearing back. There may be something that's adaptable that we can work with, that we can help each other. So those are sort of the 3 global points: time, trust, and control, which then funnel down into the bullet points that Dr. Kanamori has put up so well here. That's what I have for you.
Thank you. Thank you, Stephen. And I will also highlight that Stephen has always been open to travel to everywhere in the country and attend our conferences, our meeting with NIH, our meeting with CFAR. And I think that that has been very important because people at NIH already know him so well. He has become a celebrity now, scientific celebrity. And that is, I think that is important because the program officers also know about our partnership, and that shows that increases their interest in our project. So the time is up. And are we going to have questions now, or okay? So, Steven, can you stay for a few minutes? They may have some questions. You may be more interested than me, so they may ask you questions. So, do you have questions? No questions? Yes.
First of all, thank you so much for agreeing to share with us this morning. Truly appreciate the deep partnership. It's clear that you all have a great relationship. My name is Dr. Bernadine Waller. I am hailing from Columbia University, and I am interested in expanding partnerships. So I already have some existing partnerships, but I'm interested in expanding my partnerships. So in doing so, what, I guess, advice would you give to an early career scholar who is looking to deepen their relationships with organizations like your own in the community?
Thank you for the great question. So when you say expanding your partnerships, you mean increasing them numerically, adding new community partners, as opposed to expanding the number of projects you have with your existing partners, correct?
That is correct. Thank you.
Yeah. So you're asking, how can you get new partners? If they're willing, perhaps the best thing you can do is work with your existing partners and have them disabuse people of this scary notion. Oh, working with universities, it's too difficult. I don't. We've never done it before. We've never done research before. You can talk them into it, but wouldn't it be great if you can get a conference call with one of your existing partners, just like we're doing here, and they can say, universities aren't the bogeyman. They're not going to, have you flip your services entirely. They're not going to push your mainstay services out of the way. They're not going to dictate to you. I can stand here and validate that the doctor's approach is a partnership and not obstructive to your regular services. I think that's probably the best way to add people.
And I will share with you how our partnership started. I think that you should be your best advocate, and what I did, I should share my research interest with everybody. And I just tell everybody, this is what I want to do. I'm looking for a community partner, and blah blah blah. And I told all of my friends, a friend of my friends, and blah 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 blah. And with social networks, I was able to find the connection. So it ended up that one of the best friends of my husband knew Steven, and one of my best friends too. And I said, like, oh my God, do you know this person? Yes. And we scheduled an appointment, and this is how we have our first meeting. I recall that Steven asked me, so what do you want, or what do you want to do? And I say, well, it's not that what I want to do, it's what we can do and what we will be doing, because I was very lucky to have a K99. So I said, this is a great opportunity to build a long-term relationship and have larger RO1s in the future. So this is how it started. So you should be your best advocate and share your ideas with everybody. And then you're going to find the right person who is going to connect you with the other person. Yes. Now we have Steve Saffron, who you know as star here and director of SHARM.
Hi, thank you so much for doing this, Dr. Fallon. It's great to see you on Zoom.
Great here.
One of the things that we sometimes struggle with as a big, working at a kind of big institution, University of Miami, is that when we go to a community partner, there may have been a history already. And so if I go in and I say, oh, we're from University of Miami or CHARM or whatever, it's some places might have had positive experiences. Some people might have had middle level experiences. Some people might have had one or two bad experiences, And so it's hard to kind of break off of I think community agencies just see like as like a whole unitary thing. And me trying to say, oh, trust me, I'm different, or I'm not like the others, or whatever, like just going on what you were just saying. And I think Mariano's done such a great job as an exemplar, and how to like really make sure that everything's bi-directional, or not even, even better than bi-directional. It comes from the beginning. And sometimes we do have projects that we just have to like design, and then I don't know. So I guess there's a question here just in terms of more advice about how to get past the, I don't know, prior institutional history component.
It's a great question. And Dr. Saffron, I mean, you could just roll out your dogs and show everybody how cuddly they are, and everybody would want to sign up with you. Yeah. But most people who have bad experiences, it's either the PI or the institution. So the first thing I guess would be to say, we're a clean slate. We do things differently here. If you had a little trouble with a prior PI at our institution, tell me what the issues were. We'll work on how we make sure that doesn't happen with this. And by the way, what are those types of problems? Well, researchers are under time pressures, just like community clinics are under time pressures. And sometimes their desperation to get their recruitment, both the number of participants they need and the validated participants can come through as sort of a drive-by frustration that can seem like negativity. So there's a moment to look in the mirror for PIs as well, no matter which institution, the last one or your new one, and say, was I ever channeling my stress or dumping the blame on the partner? There's a chance for all of us to look at that. But if you're a new partner, if Dr. Saffron's coming in and we had a different partner at XYZ University before, they can say, well, this is a new study. I'm a new potential partner. The name of the university doesn't dictate everything. Let's talk about those experiences you had and what were the stumbling blocks, and let's figure out how to solve those in advance. Now, beyond the partner PI, there's the partner entity, in this case, the university, and we want to be realistic. We don't want to mislead people. There are slower processes on things like payments for community clinic participation to universities than you're likely going to get from your straight up grants. Let your community partner know the realistic timeline, but also monitor, make sure things don't fall into that big hole in universities and payments don't go out, because you're probably going to have some staff paid by the community partner or clinic who are covered by that grant. We're fortunate now compared to where we were a few years ago. We have good cash flow and we can absorb a delay on payments. But particularly, I'm thinking about some of our earliest research experiences, 10 years ago, and we needed every one of those monthly payments not more than a month or two late, because we were paying people's salary and fronting that money. If it's feasible for you, and I know we have people from universities all around here, see if your university will allow you to write up just a straight fee-for-service contract. I was speaking with Dr. Kanamori about this yesterday, because we're doing this with one of the universities. If you want a certain staff member to be available to work on your project, and you say they have to start on X date, that means that the agency or clinic has to either hire them or move them off another grant. And if there's delays, that doesn't mean the agency doesn't have to pay them. So there can be all sorts of hiccups in the payment process. If you just say, look, it's this many dollars, we're predicting it's going to start October 1st and it's going to end a year from February. We're going to pay you this many months. Let's just divide it out and pay you those months. Let the community partner therefore plan ahead. So if the study starts late, they don't have to fire the person they hired just for your project. And then I know they're using up the money in advance. You haven't started your study because you're still waiting for your IRB or whatever else, your devices or whatever else it might be. But now they can plan for that on the back end. Okay, don't worry, we'll keep paying the guy even though your funding's exhausted. We'll keep paying him those final 2 months because we knew this was coming for a year. As opposed to, I need to hire him July 1st. Okay, we've hired him, he's in place. Oh, but we're not ready to start. It's going to be, now September, actually October 15th. Organizations, nonprofits often can't deal with that type of flux in the budget. So if you're able to do fixed rate payments, or fee for service just straight up, rather than these reimbursements and, well, this was the study started then or not. That could really help. It may or may not work with your university. If it does, you're going to snatch a lot more community partners.
And I want to add that we experienced some issues because we submitted the invoices and everything, and we thought that Latino Salud was already paid. After 1 year, we learned that they never got the check, and nobody told us, So those are some things that are out of our control, really. Now, the other thing I want to just add from your answer, Stephen, is that when you have a partnership with a community organization, you also have a partnership with the community.
Oh,
So,
absolutely.
for instance, when we are working with other community organizations in Homestead, so the community already told the community organization about the work that we are doing, and they actually, when I approached them, they said, "Oh, I was actually waiting for your call. I want to work with you," and you need to ask them what are their goals. It's not everything is not about you. It's about them as well. For instance, we had the conversation with Dr. Fallon and said, "What would you like to have now? How can we help you?" And said, "I would like to have a PrEP program." And that was a few years ago. And said, "Okay, so let's work on that. Let's send these pilots. Let's go this." So then Latino Salud can have their own PrEP program that now is a reality. The same with our community partner, Mujer. As what do you want to have? And said, "I want to have a new space, a new building." Okay, so let's work on that. We spent weekends writing grants so they could get funding for their new building. Well, it ended up that then after 3 or 4 weeks, they got 1 million for the new building, but it also requires they also need your time for their own benefit, for so you need to dedicate your personal time and work with the organization. This is not a war. A CBPR is not a war that ends. It's not from 9 to 5. It's, it goes late. Sometimes you need to meet with the community organization for their own meetings, for their own advisory boards. You need to work in their own grants, not your grants, but you need to write their grants because they don't have that skill. Sometimes you need to write the grant and they say, like, "Oh, yes, I have that idea, but I didn't know how to express it." Okay, so now you have this idea. And I think that is how you train the organization as well, to grow. So yes, we have one last question.
A second plug for fee-for-service contracts. That is an excellent idea. I just wanted to add to what you were saying, and so like institutional pushback. I wanted to build something in a hospital that was the teaching hospital for our university, and I needed substance use treatment providers. So I went to those substance use treatment providers, and I was like, "I want to learn about your experiences interfacing with our hospital. What sucks? Like, why? What's difficult about working with us?" And they're like, "Well, it takes too long to verify medication. You don't send a medication record when you send the patient over, and like XYZ." And I said, "I will fix all of those things for you." And I did. I fixed all of those things for them. And then now I have social capital, right? And so now I'm like, "Hey, here's some things I would like to work on. I would like to build this treatment pathway and offer like red carpet linkage with your organization. Could we work on that?" Right? And much more amenable to my needs now that I've fulfilled their needs. And so that's always something I have discovered really successful, is just fix what they need fixed first and build social capital. And then you can be like, "Hey, friend."
What a wonderful, creative way you've attacked that. Congratulations.
Yeah.
That's a good question. Can you hear me from here?
Yep.
All right, perfect. I think we also need to think about, and I think it comes back to the equitable research, which means we need to make our research. Oh, can you hear me now? Is there a difference? Okay.
It's better.
Oh, perfect. We need to think about equitable research, which means our collaborators need to have access to our research and the research process, right? And oftentimes we're not working with people that have PhDs. There's this power differential that exists on, I have the knowledge, you don't have the knowledge. And so how do we uplift our community to gain the knowledge to be citizen scientists? Because they're doing research in real time. They know what the questions are. They know the answers to the questions. And now we have to run a 5-year study to answer that question. You know, it builds this power differential that shouldn't necessarily exist. They know how much these grants are when we write to NIH. They know the indirect costs that we get on them, right? And so when we think about equitable research, we need to think about uplifting the community to make everything equitable in the research process in that sense. So just want to say that.
No, I appreciate that. And this is, I know I just keep blowing sunshine on Dr. Kanamori, but we had this conversation just the other day because he was proposing the budget for the current year. And I looked at how much we've increased salaries, you know, as we all have had to do. It was what, maybe 5-6 years ago, we decided that we were going to try to pursue the Fair Wage Act and make sure that the $15 an hour was the minimum, and we blew right by that in not even a year and a half. So we have currently for our staff who don't even have a college degree, the minimum starting salary is $18.50 an hour, but we're trying to go way past that. And so the budget that we used, you know, a few years ago is outdated, and Dr. Kanamori stretched that. Exactly to your point, there is a perception out there that universities have an overhead line item of 46-48%, and they'll get a $500,000 grant and say, we have 50,000 of this for you. Leaders like Dr. Kanamori are much more equitable about that. And then it gets us all creatively thinking too. Somewhat unrelated, but I think this is really cool. Latina Salud launched a Health and Support Services Pride Scholarship last year. And so we're now investing directly in the education of people, some of them with seeking a MPH or a PhD in research, some of them going to nursing or social work, and investing directly in building that equitable capital that you speak of.
I think that UM is going to hear good news pretty soon, and that is a good way to collaborate. Students from UM are going to go to Latino Salud, gain experience, and Latino Salud staff are going to learn from a doctoral student from UM. Thank you, Stephen. It's always nice to see you and to present together. I'm glad that today you didn't make fun of me as generally you do. Thank you.
I can't see your shoes today, Mariano. They're always better than mine. It's just jealousy. That's all it is. Take care, everyone.
Okay, bye. Thank you.